Chapter 19 is over GI problems. So the GI system functions are to take in fluids and nutrients. We call this food, right? Break it down so the body can use it, absorb what's necessary, and then get rid of the waste. The GI system includes the GI tract, which is a hollow tube. It's about 25 feet long in an adult. It's also called the digestive tract or the alimentary canal. It goes from the mouth to the anus. The GI system also includes some accessory parts like the pancreas, the liver, the gallbladder. So the food sits in the stomach where gastric juices break it down. Then it moves to the small intestine or small bowel where parts of the digested food are absorbed. Then the waste goes to the large intestine or large bowel where it absorbs fluid from the waste products as they move through the colon and form stool or feces. This movement or peristalsis moves it along. It's this muscle, like worm-like muscle movement that moves the food along and causes stool to enter the rectum where it's stored for a bowel movement. These movements can be triggered by the food arriving in the stomach or by physical activity like getting out of the bed in the morning or going for a run or whatever, and it results in the sensation that the bowel needs to be emptied. So some issues of the GI system are nausea and vomiting. These are defense mechanisms in the GI system. They're signs of altered body function. So nausea is an unpleasant sensation or the need to vomit. Vomiting is the forcing of the stomach contents up through the esophagus and out through the mouth. The process of vomiting consists of 3 phases. First, we have nausea, then we have the retching, and then the actual vomiting. It's a reflex. It's not a voluntary action. It involves interactions among the nervous system, the vestibular system, the vomiting center of the brain, and receptors within the GI tract. Some things that cause nausea and vomiting are certain medications or treatments, especially like chemo. Also issues with balance, vertigo, motion sickness, also pregnancy or infection or increased intracranial pressure. Post-operative, like reactions to analgesics or anesthetics, or central nervous system problems. Nausea and vomiting are not only stressful to a person that has these experiences, they can also create complications like bleeding, aspiration pneumonia, dehydration, reopening of surgical wounds, which can lead to longer hospital stays. Nausea and vomiting often happen together, and the same drugs are used for both problems. We call these antiemetics. Emesis is vomit, so these are basically anti-vomit drugs. They all control nausea and vomiting. So we have phenothiazines, anticholinergics, antihistamines, 5-HT3 receptor antagonists, and dopamine receptor agonists. Each drug affects different receptors, and some affect several different sites. What you need to know about the mechanism of action is that they all inhibit or disrupt the vomiting reflex pathway. So for all antiemetics, the intended responses are to inhibit or disrupt that vomiting reflex pathway. Some of them also cause a sedative effect that helps control the sensation of nausea. Some side effects are going to vary with the drug type, so make sure you look at the table that's titled Common Side Effects of the drugs, and this is on, let's see, page 342. Adverse effects also vary with the drug types. Phenergan, Compazine, and Reglan can cause neuroleptic malignant syndrome, which is a rare, life-threatening side effect where dangerously high body temperatures can happen. Neuroleptic malignant syndrome signs and symptoms are fever, respiratory distress, tachycardia, seizures, diaphoresis, blood pressure changes, pallor, fatigue, severe muscle stiffness, and loss of bladder control. Promethazine or Phenergan and prochlorperazine or Compazine can also cause neutropenia, which is a decrease in the number of neutrophils or white blood cells, putting the patient at risk for infections. Respiratory depression, which is a decreased drive for breathing, is a life-threatening effect that can happen with cyclizine or promethazine and scopolamine. So before we give antiemetics, we want to know their baseline vitals, level of consciousness, weight, and electrolyte levels. I want to know their bowel sounds. I want to check for abdominal distension and make sure that I know the complete list of drugs that they are currently taking. I want to continuously monitor for episodes of nausea and vomiting because I want to know the effectiveness, right? I want to monitor those vitals, weights, the status of their abdomen. I want to report immediately any signs of respiratory depression and watch for signs of side effects or adverse effects. If a drug is given intravenously, be sure to dilute it first to decrease the risk of tissue necrosis in the IV site. Again, after we give them, we want to monitor that effectiveness. Monitor the level of consciousness, watch for those sedative effects, especially with older adults. If these drugs cause GI symptoms, give them with food, milk, or a full glass of water. Teach your patient to be cautious about driving or operating heavy equipment, especially until they are aware of the effects of these medications. A lot of them have a sedative effect, which can be harmful if they, are becoming sedated and they're out driving, right? Instruct them to use sunscreen and wear protective clothing and avoid tanning beds because of the potential for photosensitivity. Teach them to monitor their body temperature every day. Report any abnormal signs and symptoms to the prescriber because, again, that fever is going to be one of the first signs of that neuroleptic malignant syndrome. Remind them to get approval from their prescriber before they take any over-the-counter drugs. And we want to advise them not to use any other central nervous system depressants like alcohol, antihistamines, or other sedatives or tranquilizers or sleeping drugs while they're taking these meds because that will increase that sedative effect, possibly to the point of danger. Teach them to eat foods with increased bulk and fiber and about the importance of drinking enough fluids to prevent constipation as well. So in our kids, we have to be careful because they might have muscle spasms and trouble with balance, especially with higher doses. Most of these drugs have low to moderate likelihood of causing birth defects or fetal harm, but women do need to check with their prescriber before they take these. And some of them do pass into breast milk, so we'd want to avoid them with breastfeeding. In our older adults, they're more likely to have side effects like confusion and dizziness, shaky hands, and balance issues. And another GI issue we have is constipation. So just about everyone will experience constipation at some time in life, often because of a poor diet, okay? Most episodes of constipation are temporary, they're not serious. Constipation is technically less than 3 bowel movements in a week. When you're constipated, the stool is hard and dry and difficult to pass, so bowel movements can be painful. Common causes are abusing laxatives because the GI system kind of learns that it doesn't need to work on its own anymore if we overuse laxatives. Bowel disease, life changes like pregnancy, aging, traveling, dehydration, drugs, not having a bowel movement when you need to because the longer that stool sits in the rectum, the more fluid from it gets absorbed, so it gets hard and dry. Lack of physical activity, medical problems, not enough fiber in the diet. There's a list of different drugs that can cause constipation. This list is on page 345 if you want to read it. You don't need to memorize these. The biggest one you need to know is opiates. Opiates are huge for causing constipation. In constipation, if symptoms are severe or if they last more than 3 weeks or complications like bleeding happen, a healthcare provider should be informed. The purpose of drugs for constipation is to help the body eliminate those hard stools. Lots of people buy over-the-counter drugs to self-treat their constipation. It's important to remember that laxatives, which are drugs that are used to produce bowel movements and relieve constipation, are not meant for long-term use. They should not be used for longer than a week unless they're prescribed to be used for longer. Long-term use of laxatives can cause other health problems. Emollients or stool softener drugs soften the stool, letting the stool mix with fatty substances, making it easier to eliminate. Drugs like lubricants coat the surface of the stool and help it hold water so the body can expel it more easily. Stool softeners and lubricants make the mush. Laxatives give the push. So you need mush and push in order to have a bowel movement. These are all grouped together too. So remember that laxatives give the push and stool softeners and lubricants make the mush. The intended response for all of these is for the stool to pass and to relieve or prevent constipation. The side effects for these are going to vary depending on the drug. So refer to the areas in the book that discuss the specific side effects for each drug or drug class. In these, severe life-threatening effects are really rare. Some can cause allergic reactions or electrolyte imbalances, so those would be the big things to know there. So drugs for constipation should not be given to a patient that has undiagnosed abdominal pain or acute abdomen because these drugs increase peristalsis and the risk of a bowel perforation. So before I give these meds, I want to check a complete list of the drugs that they're using. I want to know their current bowel habits, and I want to monitor or check their abdomen for distension. I want to make sure that they still have bowel sounds and things like that. I want to know their baseline vitals, and I want to make sure that I give plenty of fluid with these drugs. I want to continuously monitor their abdomen for distension and monitor their bowel sounds, monitor their bowel movements, and assess the stool. Teach your patients to take these, if they're taking them at home, take them with plenty of fluid. Keep a record of bowel movements. Tell them that the normal bowel patterns are going to vary from person to person and help them determine their own normal pattern. They need to drink plenty of fluid every day. That's a huge thing. I can, I can increase the peristalsis to move the matter through the GI system and things like that. But if I don't have enough fluid, then I'm going to really struggle with lubrication to get that stool out. Remind them that they should only be used short term. So if their constipation is not relieved, or if they have rectal bleeding or signs of electrolyte imbalance like muscle cramping or pain, weakness or dizziness, they really need to contact their provider. And I don't want them to take these within an hour of taking antacids because antacids kind of block the absorption of these meds. In our kids, they're usually going to take smaller doses, but really they shouldn't be taking these without instructions from the prescriber. Most of these drugs are safe for pregnancy and lactation, but again, they'd want to contact their prescriber there to make sure. In our older adults, constipation is common, and most constipation drugs are safe for them to use. Laxatives, a lot of older adults use laxatives for a longer period of time and at higher doses, so they are at risk for diarrhea and fluid imbalances and things like that. And then we have diarrhea. So again, this isn't a disease, it's a symptom of different issues. So diarrhea is an increase in the amount of water in the bowel movements and in their volume and frequency. Diarrhea can happen suddenly, and it usually disappears in a few days, even without treatment. In diarrhea, absorption is decreased and secretion is increased. So it can cause dehydration, especially in our babies, and it can be dangerous because of the possible cause of electrolyte imbalances. So sometimes we do need to treat it. Some common causes are different drugs, food poisoning, abdominal surgeries, medical conditions, nervous system issues, infections. There is a box on page 349 that discusses the common causes of diarrhea, as well as different drugs that can cause diarrhea. The big ones to know are obviously laxatives, but also antibiotics. Those are the two things I really want you to know about drugs that cause diarrhea, antibiotics and laxatives. So we have 4 types of diarrhea. Don't worry about memorizing them, but if you do think it's interesting, there's a box that discusses it more on page 350. So drugs for diarrhea are anti-diarrheal drugs. We give these to control diarrhea and some of the symptoms that happen with it. When diarrhea is caused by an infection from bacteria or parasite, anti-diarrheal drugs can make the condition worse, actually. When we have an infection or a bacteria or parasite issue, we want the body to get rid of it. So if we stop the diarrhea, it's going to take longer to get rid of it. In these cases, we want to treat other symptoms like dehydration or electrolyte imbalances and give antibiotics to help get rid of the infection, but we still want the patient to pass the stool. So it's important to know that about diarrhea. It's the body's reaction to some sort of irritation in the GI system, and sometimes we need to get that irritant out. We have 3 types of anti-diarrheal drugs Anti-motility drugs slow the movement of stool through the bowel, allowing more time for water and essential nutrients to be absorbed. Absorbent or adsorbent drugs remove substances that cause diarrhea from the body, and anti-secretory drugs decrease the secretion of intestinal fluids and slow bacterial activity. In any case of diarrhea, we also want to make sure we correct the underlying problem and work to treat other symptoms too. With all these meds, the goal for diarrhea is to be decreased and for the fluid in the bowel to be reabsorbed. Side effects are not common, but they do vary by drug. The big one here is constipation, and that makes sense, right? Like if I'm giving you a medication to decrease your diarrhea, you can definitely get constipated from it. There's a table on page 351 that lists the common side effects of anti-diarrhea drugs, so definitely take a peek at that. Adverse effects are also rare, but calcium polycarbophil can cause intestinal obstruction. With all anti-motility drugs, toxic megacolon can happen. There's a picture of toxic megacolon on page 352. It's a very inflated colon with abdominal distension. Signs and symptoms other than abdominal distension are fever, abdominal pain, rapid heart rate, and dehydration. So before I give these, I again want to know a complete list of drugs a patient's taking. I want to know their baseline weight and their vitals. I want to check their abdomen, and I want to monitor for dehydration. I'm going to continuously reassess their bowel sounds and for abdominal distension. Watch for signs of toxic megacolon. Monitor their vitals, monitor their diarrhea, and their skin turgor. That's how we assess for dehydration. When a patient's dehydrated, if you gently pinch and lift the skin, usually on the back of the hand, it'll form like a tent. In someone that's properly hydrated, the skin will snap back into place. So we use the sternum or the forehead to test for tenting in an older adult because the skin on the back of the hand can tent due to aging. Ask patients about allergies or unusual reactions to aspirin or other drugs that contain aspirin, because bismuth subsalicylate or Pepto-Bismol contains an aspirin-like drug. Be sure to document the consistency, odor, and appearance of the stools as well. Teach patients to take the drug exactly as prescribed, not double dose. It can cause constipation. Avoid driving and activities that require alertness, especially until they're aware of how the drug affects them. If they don't have relief in 2 days, or if a fever develops, or abdominal pain or distension happens, or there's blood or mucus in the stool, they need to notify their prescriber. I also want them to avoid alcohol and other central nervous system depressants. Teach them to use frequent mouth rinses, oral care, and maybe even chew gum or candy or something like that to help relieve their dry mouth. Teach patients that a lot of these drugs can turn the stool and maybe even the tongue a grayish black color, so that's something that they should be aware of as well. Our pediatrics should avoid bismuth subsalicylate because it contains aspirin. You might say that there is a Pepto-Bismol for kids, but the ingredients are different. So make sure that they are using children's Pepto-Bismol, not adult Pepto-Bismol. It can cause Reyes syndrome, which is a life-threatening condition that affects their liver, central nervous system, and it causes vomiting and confusion. It's just a big problem. Infants and kids are at higher risk for dehydration as well, so we need to monitor that. In pregnancy and lactation, they need to talk with their prescriber before taking any of these. Pregnant women should also ask about replacing lost fluid because dehydration can cause them to go into early labor. Our older adults are at increased risk for dehydration as well, and we do not use bismuth subsalicylate, specifically kaopectate, because they're more likely to experience side effects with it.